We're going to needle large intestine 11. Large intestine 11 lies midway between the biceps and the common extensor origin. So we're going to needle into this point. So we've got our tray available, and we have various different sizes of needles, and the size of the needle that we use will depend on the depth of the point. And for this particular point we're going to insert the needle between 1 and 1.5 chun, so we're using a 30mm needle. All of the needles are predisposable and they come in small packs, and inside the needle is contained within a guide tube. So we draw the paper around and withdraw the needle, and you'll notice that the needle is held into the tube by a small plug. Now there are several different sorts of needles, and you may see needles which have a plastic handle where the plastic is connected to the guide tube itself. So where we have a plug, we hold the needle horizontally, we take the plug away, place that in our waste bin, hold the needle in a horizontal position so that it's not going to slide from the tube, and then we grip the needle between the thumb and forefinger of one hand so that when I move the needle vertically we are not going to lose our needle. Orientate yourself to the area, and we've marked the area itself. So what we now do is place the end of the guide tube onto the skin, and we would need to tap the needle sufficiently so that your finger reaches the end of the guide tube. That way the needle will go through the skin quite quickly. If you hesitate or if the needle scratches the skin, it'll be far more painful. So we tap the needle, withdraw the tube, hold the needle, the handle of the needle rather than the needle shaft, press the needle to its required depth. And then once we're into that area, you'll notice that I'm stretching the skin slightly to give myself a sort of a drum surface, a firm surface, as that's more comfortable for the patient. And I'm going to wait to see if there's a sensation which builds up initially. This is our de chi sensation, also called sensory propagation along the channel. And what we want the patient to feel is a feeling of an achy sensation travelling down through the forearm and up to the shoulder. If they feel that straight away, then we may not necessarily need to stimulate the needle further. If they don't feel it, we need to stimulate further. And we have several different methods of stimulation that we can use. For the first one, it's a very light method of stimulation, and we either flick the needle or we can just stroke the needle with a thumbnail so that we get a vibration passing down the needle shaft. Secondly, with the skin stretched, I can rotate the needle to and fro. And by doing this, I'm winding the fascial fibers around the needle shaft. If I want to make that stronger, then I just increase the diameter of the rotation. And then finally, I can withdraw the needle from the skin slightly, keeping the needle tip inside the body, and then press more firmly. So I'm drawing the needle out and then I'm pushing in. So I'm getting my fascial fibers, which have gripped to the shaft of the needle, to move up and down with the needle itself. Now, if you have somebody who reacts quite well, we would call them a strong reactor, somebody who has a marked histamine response. For example, if they get a bee sting or they get stung by a wasp and they react very heavily, that would be a strong reactor. There's less stimulation required. For somebody who's a weak reactor, then we have a greater amount of stimulation. Once I finish my treatment and I come to withdraw the needle, as I pull the needle, you'll notice that it pulls the skin up slightly. And that can be uncomfortable for our patients, so we need to push the skin down. But we don't push the skin down with our own fingers because the needle itself is very flexible and it can flick towards our finger and cause a needle stick. So we either push the needle down with the guide tube itself, or we push down with a Q-tip. And as I push down with the Q-tip, I'm pulling the needle up. The needle goes into the sharps bin. and then I now have my cotton wool available to compress that point. If you're not using a Q-tip, then you would use a cotton wool ball, compress that point, and that then goes into the yellow bin if it's soiled. When we're putting our needles in, we need to consider the vertical distance below the skin surface for safety. So, for example, there may be a nerve running underneath or a major vessel. So a perpendicular insertion, which is at 90 degrees to the skin of 1 centimetre, means that we're going through the skin surface to a depth of 1 centimetre. But if we're doing an oblique insertion at 45 degrees or at 60 degrees to the skin, the vertical depth is considerably less. And if we are using a transverse insertion where we're simply going into the skin fold, the needle, once the skin fold is released, will simply rest onto the tissue beneath. So we're going now onto our lung 7. And we're going to use a transverse insertion because this point lies on the radial aspect of the forearm directly over the radial bone itself. So we don't want to put the needle tip onto the radius. So we find our point, which lies 1.5 chun from the center of the anatomical snuff box. So we can abduct the thumb, find the center of the snuff box, move up by 1.5 chun, which remember is 2 of the patient fingers. Now, when you do that, you'll feel a sensation change to your palpation as we lie between the abductor tendons of the thumb and the brachioradialis. So we're at an area where clinically you can get friction causing Orsman's wrists as the tendons rub over the bone itself. So we're 1.5 chun from the center of the snuff box. Our insertion depth is going to be between 0.5 and 1 chun. So we need a needle which is appropriate for that. So we've chosen either a 13 or a 15 mil needle. So we take the needle out and I'm going to place the needle tube onto the skin surface. And rather than tapping the needle, because we're very close to the bone itself, it's a rapid squeeze of the needle through the skin surface. I then gather my skin fold and the needle presses into the skin fold, coming along the length of the meridian. So the meridian itself is traveling from the axilla down towards the thumb, so we're going into this line. And when I'm using my oblique insertion, I can either angle it towards the body, and traditionally that would be used for organ type problems with the lung, or I can angle it towards the thumb, and traditionally that would be used more for points affecting the wrist and thumb tendons. Once I have that needle in, I stimulate to feel the Dirty sensation, so the patient starts to feel that dull ache, and I want to feel as a practitioner a change in selective tissue tension. So I want to feel that needle stiffening slightly. Traditionally we call that needle grasp, where the fascial fibers are winding around the needle shaft itself. As I come to take the needle out, I'm drawing the skin away from the needle, and I have my cotton wool ball or my Q-tip ready to compress the area should there be a small spot of blood, and that is then disposed. Go to needle pericardium 6 now, and pericardium 6 is the traditional anti-hemetic point, the anti-sickness point, and part of its effect seems to be a change in vagal tone through stimulation of the median nerve. Now the point itself lies 2 chun proximal to the wrist crease. But obviously as we look at the wrist crease, we can often see several different lines. So it's the bony wrist crease that we use. We slide our fingers down and find the actual bony wrist crease itself. And then our 2 chun measurements is 3 of the fingers, and remember it's the patient fingers that we're looking for. And this point is needled in 2 different ways. It can either be a perpendicular insertion from 1 chun, or it can be an oblique insertion 1 to 1.5 chun. Now, interestingly, both of those are designed to try to protect the median nerve and to ensure that the needle doesn't go through the median nerve itself. Although traditionally, the intensity and description of the dirty sensation would suggest that often with a traditional acupuncturist, the needle does penetrate the median nerve. And there have been real-time ultrasound studies to show us that this is the case, that the needle penetrates. So if you suddenly feel a shooting sensation, an intense dirty sensation suggesting more nerve penetration, you wouldn't stimulate that needle further. So the dirty sensation itself would be a dull, diffuse ache, whereas penetration of the nerve would be more an electrical stimulation coming right down to the fingers. So we're going to choose an oblique insertion from 1 chun. So we're going to use our medium needle. So we have a 30 ml needle here. Take the needle from the packaging, remembering to hold it horizontally when we take the needle plug. So we hold the needle and the tube as 1 unit. Bring it down to the forearm, and you can notice that on this subject there is a superficial vein close to the point. Now, obviously we're going to try to avoid penetrating the superficial vein simply because of the chance of superficial bruising. And one of the methods that we can use is to actually move that vein out of the way with the end of the tube. So I put the tube down onto the skin on the other side of the blood vessel, and I press slightly to the side. So we're coming 2 fingers, 2 chun rather, 3 fingers from the wrist crease, and we're going between the 2 prominent tendons of palmaris longus and flexor carpi radialis. Place the needle onto the skin surface, strike rapidly to ensure that it breaks through the skin, stretch the skin if the skin is puckered up, and then slide the needle in obliquely along the length of the meridian. And the oblique angulation can either be towards the body, which tends to affect traditionally the organs more. So this is the pericardium, which would be used for angina type pain. If we angle towards the wrist, traditionally it's used more for wrist symptoms. Once we have that needle in place, we can then stimulate our needle to get the dirty sensation to be perceived. Once we come to remove the needle, remember that the skin can be pulled up and that can be quite painful for the patient. So we want to push the skin down and be prepared if there is a spot of blood just to dab that area. So we either use a cotton wool ball or a Q-tip. So I'm pressing the skin down, withdraw that needle. Needle goes into the sharps bin, and if there is a small spot of blood onto the Q-tip, then we throw that into our clinical waste. So coming now to the eyes of the shoulder, large intestine 15 at the front and triple energizer 14 at the back. And we're going to needle large intestine 15. Now traditionally, to find this point, it's said to be the anterior hollow of the shoulder, which of course is the arthroscopic access point. The problem is that when we abduct the arm, the head of the humerus may not necessarily be central to the glenoid cavity. So where we have tightness anteriorly, the humerus will be drawn forwards, and if that's the case, the anterior hollow can disappear. So it's more accurate to simply use the palpation of the acromion and to say that the anterior point, our large intestine 15 point, is at the most anterior portion of the acromion, and then we slide down into the palpable sulcus, and the sulcus itself lies between the anterior fibres and the middle fibres of the deltoid. So we lie our patient down and we support the arm on a pillow. So we're looking now at the eyes of the shoulder, large intestine 15 at the front and triple energizer 14 at the back. And we're going to needle the front one, which is our large intestine 15. And in order to find these, the traditional method is to abduct the arm, and as we do that, we're at 90 degrees. We can then find the anterior arthroscopic access point. Where the patient can't abduct to the arm, we abduct as far as is comfortable, and then we use our palpation skills to locate the acromion, and then we draw down from the acromion so that we're in the small sulcus, which lies between the anterior fibres of the deltoid and the middle fibres. And we're going to put the needle in by one chun. If we use a deeper insertion and the traditional angulation, which is towards the center of the axilla, we are in danger of penetrating the capsule of the joint on a very lean subject. So we're going to use an oblique insertion, aiming either along the meridian itself or more commonly towards the deltoid impression. And that way our needle can go in by one chun, but our vertical depth is less. So we're using a medium needle. The needle comes from the tube holding the needle and tube as one. Find the point itself, place the tube onto the skin, strike the needle, and then aiming towards the deltoid impression, we advance the needle. Now we're looking for the dirty sensation to be felt along the line towards the 2 points that we have already needled, coming down to large intestine 11 and down to large intestine 4. And we stimulate the needle just to increase that dirty sensation. As we come to withdraw the needle, we're using a tube or a Q-tip to press the skin down as the needle comes out, and any spot of blood we just limit by compressing, not with your finger, but with the Q-tip or a cotton bud. We're going to needle large intestine 4 now, and large intestine 4 is one of the more powerful points in the body. Traditionally it's said to be one of the 4 gates points, and it's linked with our liver 3 point on the foot. So the 2 points large intestine 4 on each side of the body, 2 points liver 3 on each side of the body gives us the 4 gates points. And we've got a couple of different methods that we can choose to locate this point. The first method is to find our metacarpal and to go to the center of the metacarpal and to slide off into the height of the adductor muscle. Secondly, we can adduct the thumb, come from our thumb crease and move slightly upwards and slightly back into the center of our thumb. Now, on the whole, the closer you put the needle to the bone, the stronger the sensation. So we're going to get more sclerotomal or bone referral from that, whereas it's going to be more dermatomal when we're into the center of the skin overlying the muscle. So the penetration depth is going to be approximately 1 chun. So we're going to use our medium needle, and we're going to adduct the thumb so that we have the mound of the muscle visible. But obviously, if the person has a thumb injury, we just do that to comfort level. Have our needle, we place it over the center of the muscle, strike the needle, press it to the required depth. So initially, we're just going to leave the needle to see if the dirty sensation builds up. Because this is a powerful point, we don't want to stimulate the needle straight away. If the dirty sensation doesn't build up, then we've got a couple of different methods that we can use, and we're going to choose the most gentle method. So the flicking methods to start with, and then gently twisting the needle. So the thrusting methods, which are more powerful, we can use, but only if the patient hasn't reacted. So we don't want to have a strongly reacting patient and immediately start with the most strong stimulus, because that, in terms of patient compliance, will give a very poor outcome. As we remove the needle, the skin is pressed down and any area of blood is just compressed to stop that bleeding.